What's up, everybody? Welcome to Solving Complex Aesthetic and Functional Problems Utilizing 100% Digital Workflows. My name's John Cranham. Lee Culp and I will be presenting this today. And this is the first course of a series of 6 courses that is available through Cranham Culp Digital Dental. And we have several different vehicles where we can be delivering that. We'll talk about that later. But today is open to the public. So some of you may be turning in live. I think the vast majority of you will probably see this on recording later. But what we're going to be talking about today is how we can harness the power of digital workflows as we try to do our dentistry, whether it's simple or complex, at an extremely high level. And this has been a passion of ours for a very, very long time. We really came together about 8 years ago. But we both definitely started in the same place in the analog world, caring about aesthetics, caring about occlusion, caring about biology. And now it's just really exciting that we're finally at a point that we have both the input devices, the software, and the output devices to be able to do really anything that we did in the analog world, in the digital world, but maybe faster, maybe more accurate, and what I certainly believe better. So my job today is to open this thing up and kind of go through some of the case and some of the principles. Lee is going to be talking about how a dental lab can support us at a very high level. I think it's important that we know, even if we've got a full service lab in-house, having that relationship with a lab that can do specific things. They need to be able to understand the workflows, but they also need to understand our goals. And you'll hear from that from Lee today. And then I want to finish up kind of going through this elusive question about why digital? Why should we go down this path? And then talk about an opportunity that is available. So first, from a disclosure statement, Lee and I are the founders and owners of Cranham Culp Digital Dental, so we do have a financial interest in that. I am a KOL and educator for Zimmer Biomet, or ZimV. I'm visiting faculty for the Pankey Institute, as well as Dental Practice Mastery. They're both playing an important role of what we are doing this year. I've got some courses available through Seattle Study Club. We also should have special thanks to both Pankey and Seattle Study Club, who are basically partnering with us to make our training available to their group. Dental Practice Mastery is going to be our partner in the 6-part series, the lecture series. Again, as I said, this is the first of 6 that you'll hear about. Benco is offering great discounts to our practices that work with us on software and some of the hardware that is necessary to do these protocols. Lee's Lab Sculpture Studios, we couldn't do this without that brilliant team, because again, a lot of the things that we do in the software weren't necessarily designed to do that. Remember, the software that we'll discuss is really developed for labs, and so this group of genius people are really responsible for a lot of the stuff that we are teaching. And also should special shout out to Jason at Dental Arts Lab. He is sort of our exocad specialist, if you will, and helping bring that information into what we're doing, has become a coach. And also Dental Arts Lab will be helping get the word out for what we are doing this year. So just first of all, with my path, I don't want to go through all this, but I've spent a lot of time with Dawson at the Pankey Institute and with Coyce and Spear and some of the cosmetic greats. And my early career was really on discussing the integration of cosmetic dentistry with tried and true occlusal concepts. I did that sort of 97 to 2000. Spent from 04 to 2000 with the Dawson Academy, and was clinical director there from 07 to 2020. And then Lee and I got together in 2020 and are doing what we do now. And since then, I've also come back as visiting faculty with Pankey. But my introduction to digital came in 2000, and I always looked at it through the lens of not just being able to do a chairside crown, which is what I was originally doing, as I learned digital. I wanted to be able to plan and to mount models and do the things that we did in the analog world to plan for aesthetics and function, utilizing mounted models on an articulator and wax. I visualized early that there could be the potential that we could do this more accurately and a lot more rapidly. And it just took a long, long time for us to get there. And it was about 2017 that Lee called me and said he thought we had something. So what I want you to see here is most of my training initially were on these foundational principles, and digital was looked at as a tool to be able to do those things faster. And that's the way I think we should look at it. I do think the greatest challenge to implementation is maintaining a balance between the effective use of these timeless principles of aesthetics, of occlusion, and biologic health with the effective execution of sound digital workflows. And that's what Lee and I have been working on to figure out, and then ultimately now teaching. So that's what we're going to go through today. Remember that it's critical for any dentist to have goals in these, what I call the 4 food groups of dentistry, but we have to understand where teeth reside from an aesthetic perspective. Not just when we might want to do a veneer, but where the incisal edge should be, where the gingival plane should be, what the width relationship should be, what the golden proportion should be, specific about tissue, heights, and all of that are important. Similarly, we want to have very specific occlusal goals. And the great thing about digital protocols is that the software doesn't know what your goals are. So you happen to be a Pankey doctor or a Dawson doctor or a Coyce doctor, you can apply to whatever principles of design that you want. But it's important for you to decide what those are. I think by and large, for a lot of us, we don't think enough about this. Think a lot about the fronts of the teeth, but we should be thinking about the backs of the teeth and the tops of the teeth equally as well. We got to have biologic health goals in terms of cleansability of restoration and probing depths and things like that. And we also have structural goals of when we're going to do a tooth for a crown, when we're going to do a filling, when we're going to take a tooth out and put an implant in, or we're going to do a post and core. These are philosophical things that you need to think about. And so for me, Pankey, spending time with John Coyce and Frank Spear certainly were important. They were together when I did it. My time at the Dawson Academy, both as a student and as an educator with Pete, and certainly Seattle Study Club. These are all ways that we can become more clear on these principles. But the key point is the most important skill set any dentist can learn is the ability to visualize precisely where they are going and develop efficient workflows to get them there regardless of the complexity of the case. This generally does not happen in dental school, and it's going to take time, dedication, and commitment to get you there. All right? So what I want to do in the opening is a little different. I'm going to flip it upside down. Usually I start with principles, but I want to talk about a case, and I want to look at Brian's case because Brian is interesting. We'll go through his problem list here in a second. But I want us to look at a case of how we can utilize both these principles and how we can utilize digital workflows to plan where we're going as well as execute the case. And then what we're going to come back and do is look at some principles of occlusion that every general dentist should know and how they apply back to Brian and how we utilize them to get predictive results. So he's 53 years old. He's a type 1 diabetic. Insulin, he takes insulin, so that's controlled. Thyroid disease, also controlled with meds. Controlled high blood pressure with meds. He has sleep apnea, but controlled with a CPAP. So he's got some spot bleeding on probing, moderate generalized gingivitis, and localized periodontitis. You're going to see also we had some issues with the height of tissues, so I involved periodontist for some crown lengthening, so he's going to manage the health of the tissues as well. He has a history of 4 bicuspid extraction and ortho. He has class 5 cervical lesions on several teeth. From a joint perspective, he has normal range of motion, normal load tests, no history of joint sounds, sore muscles to palpation. He does get headaches a couple times a week. Severe wear and breakdown, erosion, abfractions. He has no mobility. And he was referred to the practice as a patient that should be considered for all on X. I disagreed with that, which we'll talk about. But bottom line, wants to have a pretty smile. He's a pastor at a church. He doesn't have tons and tons of money. But he told me he wants what's optimum. And if there's ways to phase things, that would help him. And certainly with all on X, it's very difficult to phase treatment. So just looking at him, you can see profile, his little bit of a dished-in face here. Length of teeth is not too bad. And just looking at the retractive, we can see some of the breakdown. One of the things that we like to do is look at the facial profile to see where the mandible and maxilla is in relationship to the rest of his face to get an idea of skeletal arrangement. And I like to use Arnett's true vertical line, that if we drop a line from the base of the nose straight down, we should see the upper lip 2 to 5 millimeters ahead of the line, the lower lip on the line or 3 millimeters ahead, the chin on the line or 4 millimeters back. And when you look at Brian, well, his facial hair gets in the way a little bit. Certainly the upper lip appears back because it's basically looks like it's on the line. The lip might be pretty good, but on the back end of it, so it looks like it might be just sitting right on the line. And the chin looks forward. And so this looks like somebody whose both jaws are back, upper more than the lower, and chin forward, maybe slightly overclosed. We always do a stop-bang analysis. This is a great questionnaire. You can have your patients. You can just Google this and look for stop-bang analysis. And it is a great screening tool for airway. And he was high risk just from the screening. And, of course, then we found out he had been previously diagnosed with apnea and was on CPAP. So that made me feel good. But I don't doubt that some of the wear pattern that we're seeing is probably related to him being so broken down from the standpoint of bruxing and grinding that was probably related to having a compromised airway. Periodontally, he's got some 4s and 5s, otherwise 2s and 3s, but just some spot areas that we are going to get the periodontist to work on. And I think it was definitely taken care of through primary care, didn't need surgery. But just looking at him, you can kind of see why I wasn't really thinking there was any need for all an X here. These are restorable teeth. I was a little worried about 10, not a lot of tooth structure on 10, but I also have, as you'll see, tissues, a tooth that's erupted and the bone, the tissue has come down with it. So crown lengthening in this area is going to expose more tooth structure for me to get a feral effect. So there's nothing here that I thought needed to be removed. And looking at his smile, 3 views, you can definitely see very broken down lower incisors as well as upper incisors, but we can also see fairly good curvature to his lip, and we can look at it and imagine nice teeth being in there. We look at the length of teeth. We start with the rest position, which is this top left picture, and it's showing about 1 millimeter at 9, and we might want to add a millimeter to that. The E position, we should see this edge half the distance between the upper and lower lip. So again, rest and E is telling us adding a little length would be good. Tip down smile, we'd like to see the edge following the intervertebral border of the lip, so it definitely can be built out. And looking at the profile, you can see one of the problems in his closure is these edge to edge. So if we're going to want to lengthen these teeth, how do we do that with where the teeth are now? And this is where having a good understanding of vertical dimension is going to help us, because I certainly don't have any room to cut tooth structure away. If we're going to open this guy up, as we open, the jaw not only drops down, it drops back, so it's going to give us some room for overjet, as well as the ability to create a little bit of overbite. We can look at his gingival tissues and see definitely from starting where the height of 6 is that we can definitely come up, bring the laterals and centrals up through crown lengthening to expose more tooth and to give us that ability to grab on for some ferrule effect. So the combination of crown lengthening and building up and opening the vertical so we're not cutting any away gives us a lot of help. Looking at his lower plane, we like to say the lower incisal plane should be straight, convex, but never concave. And so looking at where his premolars are, probably a height of about the distal of that lateral would be a good place for us to create a plane that will be nice and straight, and we'll show you how we do that in the digital world. So again, he's definitely closed down. We definitely need to bring him open a little bit, and we're definitely going to open vertical dimension and do some crown lengthening to expose more tooth structure. Here's his scans and MI, and visualize if we were to try to restore him right here and cut more tooth structure away, there'd be nothing left. But if we open him like this, and this is just a CR scan, a record, a scan, a bite scan in centric relation using a leaf gauge. We'll talk about that in a little bit later. But notice that as he opens down and back. And that's exactly what we want to see. Lots of wear and tear. All right, let's look at the the video of the scan. And what I want you to pay attention to is look where the canine is in his MI. And it's very class 3, very over-closed looking. And I want you to look at him when we open the vertical about 2.5 millimeters with our leaf gauge in centric relation. So look at the canine. And now look at the canine. Remember, jaws don't drop down, they arc open. And so this falls right into a class 1 relationship. And so we can start to imagine how that increased vertical is going to give us space to add back what this guy has destroyed and how we can conserve tooth structure to do that. So we're going to take the scan that we took in centric relation with the leaf gauge at the open vertical, and we have the capacity to mount very rapidly in a variety of softwares. This is the example of 3Shape, but Exocad and RealGuide will do the same. We'll get into this a little bit more detail, but when we are mounting utilizing the Bonwell point in 3Shape, our first job is to take the scan and to align it with this little place where the centrals go on the platform. What that does is geometrically it positions the incisal edge 100 millimeters from the condyles, and this is the exact same geometry of the Coyce facial plane analyzer. And for those of you using ear bows, there was a study in JPD in 2015 that shows that this average is within the same range of the average we get with using ear bows. So the difference is we can mount on a virtual instrument in these softwares in minutes without stone, without all the process that we did in the analog world. Okay, so for me, this has been a game changer. This ability to get it on an articulator. We still have the ability to open and close on the arc. It still shows us hinge axis. So if we want to change vertical a little bit, if we want to close it all the way down and see the first point of contact, which we are here, which we expect back on the second molars, but we can work to find a vertical that's going to be pleasing to us. There we are, closing it all the way down. We certainly don't want that. But closing it down to the first point of contact, we can even analyze the occlusion and see that he does in fact have pretty significant working and balancing interferences that are going to be the primary problem. So there's the balancing interferences off the second molar. But we're going to open it back up and give this our primary place to study, locking the vertical there. And that's going to be our primary place that we start our design. Now what we'll do is start bringing teeth in. And in my plan here, I'm visualizing doing crowns first by to first by, eventually crowns on the molars. But for now, to try to phase him, we have the capacity to print little toppers that could go on those back teeth that basically open the vertical. And we can bond those in place. we use these a lot to help patients just like Brian who need a little bit of time. We also are visualizing some restorations first spine to first spine in the bottom, but you can see how we can see and design specifically good centric stops all the way around. Equal intensity stops and guidance principles we'll get to later. We believe in anterior guidance, so we're going to illustrate canine guidance in this place, make sure that they can't rub on back teeth. I'll explain why in the next section. And then we can even see specific things like crossover, where the lower canine crosses over the upper canine and how it misses the lateral and transitions right to the central. This is what we want to see. Looking at it the other way, crossing over lower canine, crossing over the upper canine and landing on the central, skipping over that lateral. Similarly in protrusive, smooth protrusive path, out edge to edge. These are the little nuanced things that when we design, whether we're going to go and print this to make help us make a lux temp print provisional, or if we are going to go ahead and utilize this file to print a provisional, those are all things that we can do. So let's look at our treatment plan here. So again, our periodontist is going to do 4 quadrants of scaling and root planing. They're going to do crown lengthening 7 to 10, so we're getting that biologically stable. We've got some class 5 lesions that we need to take care of. And we know we have buildups to do, but I'm going to do those at the time of the prep. So just kind of get the patient biologically stable. Then we're going to come in and we're going to do bonding 20 to 20. Should be 21 to 28 because it didn't have second buys, but first buy to first buy, we're going to be bonding those in. Then we're going to prep 5 through 12, do our buildups, and I'm going to bond toppers 2, 3, 14, and 15. In this functional stability appointment, it's about a 5-hour visit. We're going to transform his whole occlusion and get the teeth into position to be able to really visualize to make sure that aesthetically and functionally, my goals of aesthetics and function are fulfilled. We can have an appointment or two to equilibrate and just make sure the patient's comfortable. He's still healing a little bit from the crown lengthening surgery, so I haven't done my final scans yet. But then we'll bring him back, scan 5 through 12. We'll deliver 5 through 12, scan for the maxillary night guard, orthotic, and then deliver and do our final post-op. So understand this is going to be a 5-year plan for this patient, but at the end of stage 1, we'll have some bonding first buy to first buy that will be injection molded. Some of the posterior areas where he's got some little potholes, we'll bond those in just freehand. You'll have toppers that are bonded in place, printed toppers in place in the molars that help open the bite, and the final work will be 5 through 12. What's going to be left? There's some grafting to do, 22 through 27. We've got some molar porcelain work to do, and eventually the lower incisors will be porcelain as well. So let's just kind of go through this now and understand that once we get that digital design, we can print a model and be completely ready. If we're going to do a lux attempt type provisional, in this case we use printed provisionals that we'll talk about. But after that 5-hour visit, I had him here. So you can see the bonded toppers in the back. You can see where I've just kind of freehanded some of the bonding and the potholes. And then this is injection molded. So what do I mean by that? We basically just make a silicone index from our wax up, the digital design we did, that comes in from the lingual. And we can tie off adjacent teeth with plumber's tape, but we can inject the resin into that matrix up to the height. I still have to do some freehanding on the facial, and I've got some work to do here. It's not polished yet, but I'm just getting that plane that we visualize digitally in the mouth. And you guys have probably done something similar to that from analog type wax ups. Works great. All right, so just kind of looking at it, you can see the tissue heights are looking good, pretty level with the canines now. And I was able to just build up the linguals and get a nice ideal preps with plenty of ferrule for Brian here. There, the bite scans retracted. And what we did to print it, and this will be something that we'll certainly talk about in more detail when Lee's here, but what we basically do is when we send the scan to Lee, he will also have the file for my design that we did. And he has the capacity to, in about 20, 25 minutes, to basically take my wax up and superimpose it over the preps and connect the margins. And he sends the file back to us, an STL file of the printed. It's like the wax up, but it fits the teeth, and then we just print it. So in about an hour, we can, while I'm packing tissue and doing our final scans, we can have a provisional printed that is going to have perfect fit with the margins and be really strong because it's a resin ceramic material. But anyway, here are the scans. Again, good clearance everywhere and good retraction. And again, we're just CR and MI is the same now. So we're just having the patient bite and they will just copy from here. One of the powerful things about digital is once we have a good design, the lab can copy and paste. If they have the file where we did the design for the wax up or the file that they made the provisionals from, if we like that, then they can just cut and paste and keep using that file. This is the printed provisional in place. We're pretty happy with it. The one thing that I did notice was it was slightly to the lingual, so I want to increase his overjet a little bit more. That will shallow his guidance. I'll explain that in a little bit more detail later. And then, of course, for the lab, in the communication, I'm going to write a lab script, obviously tell them that I want those edges out a little bit more. But after we've had an appointment where we've checked the provisionals and dialed in the occlusion, we will scan the provisionals and send the lab the adjusted provisionals, the photographs of the provisionals, and a little punch list of anything we want a little bit different. The lab can then take our provisional scan and superimpose it over the prep as well as over the initial design that they've cut and pasted and make any little changes. This is an extremely powerful way to communicate. So again, just looking at it, this was one of the things I wanted. It's just a little tight here, still a little retroclance. Going to just bring those edges forward, create a little bit more concavity. I like the length at rest. I like the position of the tissues. And so we're ready to proceed to final. Just looking at the occlusion, equal intensity contacts all the way around, our guidance, and then this is going to be the scan that the lab certainly can look from. So just looking at this in a little bit more detail, we get back to here, just kind of looking around, all the contours are there. But if we look right back to essentially where we started, you look at those contours and look at it in the mouth. There's a little bit more width because we brought things forward a little bit. Our patient here thought the provisionals were a little light, so we toned things down. But again, toppers in the back. Final restorations, first molar, first bite up top. And nice looking case. This case, again, was done by Joel at Sculpture Studio. And so Lee is working hand in hand with him, but this is Joel's ceramic work. And this is monolithic from Ivoclar Zircad Prime. So it is a gradient technology that has 3Y, 4Y, 5Y zirconia. So 5Ys on the outside, 3Ys more towards the inside for strength. But all of this, all the color and contour is done with staining and glazing. And on higher functional risk cases, I like that. I did blend a little bit more resin down on the facial here on the lowers to to bring that better color match. He's going to be those for a while. The lower incisors are probably going to be one of the last things we do in his phase plan. And then the final scans and the final occlusion. Equal contacts, guidance. And where the rubber meets the road is just looking at excursions here. Do you remember that crossover? That's what we want. No rubbing of back teeth. Remember that for our next discussion. And the ability to move around smoothly without building up force. There's the scans or the x-rays of the post-op compared to the pre-op. So when we look at a case like this, I do think we should charge something for records, gathering all this data. Again, there's some hygiene stuff in here. There was an in-house design fee for what we do, our per unit fee for the crowns, some printed provisional fees, topper fees, direct bonding fees, some of the class 5 resins. I included the maxillary orthotic. So we sometimes will add a specialty fee on top of that for time, skill, and judgment. We discounted that because he was a pastor, but that was our fee for that initial case. All right. Now, what's remaining here, which he can do year by year, is next year we'll do some grafting with the periodontist 22 through 27. Then we'll do the crowns on the right side, the crowns on the left side, and then we'll come on the posterior, and then we'll come across the front. So remember, when you're phasing, the most important thing is, and again, appointment 5 is the big one, because in this appointment, where we bonded the toppers in the back, we did direct bonding 21 through 28. We built up and prepped 20 through 25, or 5 through 12. In this particular situation, he basically got us in a position that will allow us to leave the office where he's stable, right? So we basically taken him and reestablished his vertical dimension. We basically got things aligned where CR and MI is the same. And so now it's an MI case. So everything we do after this is quadrant dentistry. Very, very simple. So this whole process took us about 14 hours. It's a very decent productivity per hour. And so when we think about this now, which brings us up to our next section, which we'll look at in the next video, is think about all of the fundamentals that we needed to understand to execute a case like this. Aesthetic fundamentals about where the incisal edge should be, where the gingival plane should be. Fundamentals about biologic health, like what's the distance from our margins to the bone? How do we communicate to the periodontist? Centric relation, anterior guidance, envelope of function, all those things. So in our next section, what we're going to be looking at is the 14 factors of occlusion that every dentist must know. In this program, we're going to be spending a lot of time on really understanding that. And what I think you'll find is if you can apply digital workflows to the principles of certainly occlusion, the things we're about to talk about, and aesthetics and anabology, that will give you all of the specific ingredients for great success.